number 1. What should you consider?
Labial, melanotic,
Macule. That's right. What about oral melanotic macule or labial melanotic macule? Okay. Typically, if it's on the lip, you use the term labial, but it's okay if you guys say this is melanotic. But this is a benign lesion, and that's the critical thing to know, right? It's not a melanoma. Okay, so what is at the top of your differential diagnosis for this condition? Pleomorphic adenoma.
Is it really freely movable? No, probably not, because it's in the hard palate, it's down the bone, but I'm trying to give you clues that it's benign. I'm sure.
Go ahead.
First one, it cannot be the acquired.
because it's not round or oval. It's
But do all melanotic macules have to be round or oval? No. There's no hard and fast rule, right? So the most common thing that arises on the lip that is a pigmented lesion is a labial melanotic macule. Yes, you can also have nevi, you can have other pigmented lesions, but again, the question says what would you consider on the top of your differential, so which is the most likely entity that can present in that area. Yes.
For this one, mucoepidermoid carcinoma would not be, because why?
Because this is a benign presentation, so patient had this for many years. It's a slow-growing swelling, and if you look at the clinical presentation, it looks benign. And the most common thing on the palate, if it's a salivary gland tumor, it tends to be pleomorphic adenoma. So I would not consider it on the top of the differential.
It doesn't have any of the signs of malignancy. It's round, it's normal in color, intact surface, so you have to take those things.
And what is your best clinical diagnosis for this presentation? So this is physiologic pigmentation or racial pigmentation or ethnic pigmentation. Any of those terms, right? The patient does not have any history. The patient does not have any underlying medical conditions. So if you're considering sclerosis or Addison's disease, you shouldn't consider those because of the, what the history is presenting here. Yes. Why is it not melanoma? Okay, so if you look at what is the likelihood of melanoma actually arising in both buccal mucosa and the gingiva and a diffuse presentation, and patient having it for pretty much, it's a routine exam with no symptoms. It's unlikely, right? Because if it is a melanoma and if it has this kind of a diffuse presentation, more likely than not, you're going to have, an elevated presentation. There's going to be variation in the color. So how do you differentiate between a benign lesion and a melanoma? You look at the ABCDE, right? So is this lesion asymmetrical? No, because there's bilateral symmetry. You're seeing it on both sides. You're seeing it on both the gingiva, right? Is this, is the color variation? No, there is not. It looks the same color throughout, right? So yes, the diameter, it's a large size lesion, but so are all, diffuse pigmented lesions. They're going to be larger. So you have to consider everything in the picture before you, call it a malignancy. Yes.
Due to the white striations, I was thinking it was leukoedema. Why is it leuko?
Me too.
Okay, so the
the
question is, so the leukoedema, so if the question was about leukoedema, then it's going to be exactly, so this lesion disappears, after you stretch the mucosa. So what is your diagnosis based on that presentation for the white lesion, right? It's not, and then do you see leukoedema on the gingiva?
No.
No, right? So the question specifically said that these lesions are seen on the gingiva and on the buccal mucosa. So that would not be the right answer.
That's what you really
So you have to pay attention
It's
to
not
what's
right
being asked.
Leukoedema occurs in pigmented people who are likely to have physiologic pigmentation, but it produces quite a bit more opacity than this. This is within the normal
Very,
level
very
of
subtle.
opacity.
Okay, what is your diagnosis for this one?
escape reaction.
Escape reaction.
Loud enough. Mucus escape reaction. What is your diagnostic term that you use to describe these? Varices or varicosities or sublingual varices? All of those answers. What is the one risk that is associated with failure to treat this mass for such a long time? Facial
Malignancy.
It can get malignant over a period of time, that's right. And it can damage the, adjacent structures.
Facial paralysis.
In removing it?
Benign lesions don't normally cause facial paralysis, even when they get big. That is a sign of malignancy, so I was looking more for becoming malignant over time versus destroying it.
Metastasis?
What about
I can't hear for all the murmuring.
It becomes lymphoma transferred to lymphoma.
Okay, so this fits with a benign parotid tumor, which would not turn into lymphoma. So if it becomes malignant, it's going to be a malignant tumor. It's going to be carcinoma expliomorphic adenoma. So the choice of malignancies is critical.
So I could just put malignancy.
If it just became malignant, that's fine. But if you specify malignancy, it needs to be correct.
Oh, I just put malignancy.
That's fine, not a problem.
What's that? It looks like an ulcerated or like a...
Yeah, that's a biopsy site. They decided it was time to find out what it was.
Yeah, I thought it was an ulcer site, so that's why I thought it was malignant.
Does malignant fit with it being there for 20 years? No. So everything else fits with it benign and slowly enlarging. So we're worried about it becoming malignant. So depending on how you word it, you'll show that is last question. Yeah, that would be fine, because that's what it becomes. Sure.
Okay, question number 7. What is your best clinical diagnosis for this lesion? Do you actually see the lesion? Yes. That's the critical thing. It's a very small lesion, but it's important when you guys do an exam to look out for everything, even if they're tiny, to recognize it.
Why is it paler in the middle? Why is the dark spot paler in the middle? Something we really commonly see with amalgam tattoos. It's the scar tissue. Where it penetrated, the injury penetrated the surface to introduce the amalgam, produced a little bit of scarring. So that's why it's paler in the middle, and we see that often.
That's your amalgam.
So that's something you will notice in your patients as well.
What is the best diagnosis again, based on the clinical presentation here? Okay, what is the most common cause of xerostomia? Medication side effects, that's right. Okay, and give an example of a disease or condition, any disease or condition that can lead to macrocytosis. So there's a whole list of things. If you have answered any one of those, then you get it correct.
Can you do acquired attention?
Yes, any disease or condition.
Pass that to AJ.
AJ. This is for you, apparently.
Oh.
Okay, so our topic for today is jaw cysts. So do you guys know what a cyst means?
So it feels stop lined by epithelium.
It's a cavity, right, that's lined by epithelium. So you cannot make a diagnosis of a cyst if you do not have an epithelial lining. And that's critical because there are some that can mimic a cyst, but they don't have an epithelial lining. So we call them pseudocysts. Okay. So when we talk about different type of lesions that can look like a cyst, we'll look at true cysts and pseudocysts. So you guys need to know the difference between what is a true cystic lesion versus something that's pseudocystic. So when you look at this, so you have what looks like a cavity right in the center. So this is the lumen of the cyst, and this is your epithelial lining right around, okay? And then surrounding this cyst is basically a fibrous connective tissue wall, and that's where you're going to see inflammation, granulation tissue formation. So all of that stuff is basically is going to be in the wall. So do you guys remember tooth formation at all? Embryogenesis? Just a quick, look at some of these structures that you have. So you have what looks like, okay. if I can get that to work. So you have, this is the oral cavity, and then it basically sends a signal down to the area where the teeth are forming, and then it sends this epithelial lining right here. And this is called the dental lamina. So eventually you're going to see what looks like an inner enamel epithelium right here, an outer enamel epithelium. And then in between, you've got this really loose kind of material that's called stellate reticulum. Okay? So this is your inner enamel, outer enamel, and this is your stellate reticulum right here. And then you have the dental papilla, which eventually transforms into your pulp tissue, right? So this is, and it's important to know some of these terms, especially the term dental lamina, because when you look at cysts, and then you look at the pathogenesis behind the cysts, what they arise from. So these are some of the structures that they arise from. They arise from the rest of the dental lamina. So during tooth development, if that dental lamina doesn't completely go away after the tooth is formed, and you have some elements of this dental lamina still persisting, and some of those things can eventually give rise to a cyst. Okay, and that's why they're considered developmental cyst, because you have some of these remnants of structures during tooth development that eventually can give rise to a cyst. Okay, and this is pretty much the same thing again in a different stage of tooth development. And then you see the ectomesenchyme. You see the inner enamel epithelium, outer enamel epithelium, and this really loose material that's called stellate reticulum. When we talk about odontogenic tumors on Monday's lecture, we'll talk about an entity called ameloblastoma, and then the stellate reticulum is something critical to remember for that lecture, because the inner component of that ameloblastic cells basically looks like this. Okay, and that's why we know that these are developmental odontogenic either cysts or tumors. Okay, because of the origin of these entities. So I'll upload this onto the Canvas, the PowerPoint PDF. So you'll have this classification scheme available. So if you look at the new WHO classification of odontogenic and non-odontogenic cysts, they talk about two categories. One is developmental and the other one is inflammatory. So what does inflammatory mean? What is inflammatory? So if you're calling something inflammatory cyst, what does that mean?
Response to an antigen pathogen.
So you need to have a source of inflammation, right, in order for that cyst to arise. So if it's a developmental cyst, basically it doesn't need a source of inflammation. So the tooth typically that's associated with a developmental cyst, is it going to be vital or non-vital?
Non-vital.
Vital. That's the difference, right? So in a developmental cyst, the tooth that's associated with the cyst is going to be vital tooth, because it doesn't need a source of inflammation for this cyst to come on, right? So it's something that happens during growth and development of the tooth that actually triggers the cystic lesions to come on, right? Whereas in an inflammatory cyst, though, the mechanism is different. And I think Dr. Richards talked to you guys on Wednesday about pulp and periapical lesions, right? So did she talk about radicular cyst? Yes. So, and for radicular cyst, what was the etiology? What did you need to see in order for a radicular cyst to arise?
Infection.
You have to see a source of inflammation, right? So that means the tooth needs to have either pulpitis or pulpal necrosis, something in order to induce this cyst to form, at the apex of the tooth, right? So, and then the inflammatory collateral cysts are also considered inflammatory cysts, but here the way you see this lesion is slightly different, and I'll show you examples of that, as we go forward. But so you need to know the broad categories, which one is considered developmental and which one is considered inflammatory cyst. So typically your inflammatory cyst, the list is really short because you need a source of inflammation. The tooth tends to be more non-vital, in these cases when you see a radicular cyst, whereas in a developmental cyst, the teeth tend to be vital that's associated with the cyst. Okay, so the ones that are extremely common that you're likely to see in your clinical practice are the ones on the top: dentigerous cysts and OKCs, odontogenic keratocysts. Okay, these ones are not that common. Again, nasopalatal duct cyst is you can see that in your clinical practice, but the rest of them are not very common. Okay, so dentigerous cyst, odontogenic keratocyst, nasopalatine duct cysts are 3 common cysts that you are likely to encounter in your clinical practice. Okay, so let's start off with, the first one, right? So what do you guys see here? If I showed you this radiograph, right, how are you going to describe it? So describe the one on the top left for me. I'm sorry?
Pericoronal.
Okay, so it's pericoronal. Okay, so it's around the crown of a tooth. Okay. And first and foremost, whenever you start looking at bony lesions, you need to have an algorithm that, a way that you work these lesions, right? So you look at this, you first tell me, is it radiolucent, is it radio-opaque, or is it a mixed lesion? What would you call this? Radiolucent, right? Because it looks uniformly dark on the inside. It doesn't look like it has any, dense areas on the inside of this lesion. So this is all radiolucent, right? So it's all uniformly dark. Okay, what else? So now we established that this is a radiolucent lesion. Now what else do we say? Is it unilocular? Now radiolucent lesions can be unilocular or multilocular, right? So what would you call this? Unilocular, right? So it's a radiolucent lesion and it's unilocular. Now you tell me that it's a pericoronal unilocular radiolucency. So it's around the crown of a tooth, right? So now what is it corticated or is it not corticated? Corticated, right? So it has what looks like a bony border around the lesion. So that means, is it a slow growing lesion or a fast growing lesion? Slow growing, right? Because when you see a corticated or a sclerotic border around a radiolucency, it means that the lesion has had enough time to create a barrier around it, a bony barrier, right? And that's why you see that, cortication around the lesion. So we know this is a slow growing lesion. We know this is unilocular radiolucency around the crown of a tooth, right? So now, what type of a tooth is it associated with? Is it a tooth that's completely erupted into the oral cavity or is it impacted? It's impacted, right? So it's associated with an impacted tooth, okay? Now, if you look at the radiolucency, what is it doing? Is it running from CEJ to CEJ extension?
Yeah.
Right? So this is your cemento enamel junction. So it basically, encompassing the whole tooth, okay, and goes from cemento enamel junction to the opposite side, right? So it looks like actually the crown of the tooth is sitting inside, this radiolucency, right? It gives that appearance. So when you see this, you have to always consider dentigerous cysts on the top of your differential diagnosis. So if you have an impacted tooth, okay, and you see a radiolucency that's unilocular, okay, that appears corticated, okay, and it's uniformly radiolucent, right? Then you have to consider dentigerous cysts in your differential diagnosis. That's the first and foremost thing you will consider on the top of your differential before you think of anything else. Because there's many other cysts and tumors that can mimic this. But you always have to consider dentigerous cysts on the top of your differential if it's associated with an impacted tooth. Please do not make a diagnosis of dentigerous cysts if you see a unilocular radiolucency that is not associated with an impacted tooth. Okay, that impaction is the critical thing here, right? The tooth always has to be impacted in order to consider dentigerous cysts in the top of your differential diagnosis. So, how is this different? The picture on the bottom right. Is that any different?
Yeah.
It's pretty much the same thing. It's just a different tooth, right? So, is your diagnosis going to change now? The top of your differential? No, it's still a dentigerous cyst because it satisfies all of those features, right? So you're seeing it as a radiolucency, okay? It's unilocular radiolucency. It's around the crown of an impacted tooth, okay? You have a sclerotic border around the tooth, knowing that we know now it's a benign, slow-growing lesion, okay? And it's extending from CEJ to CEJ, maybe slightly lower, but pretty much, it looks like the crown of the tooth is actually sitting inside that radiolucency, right? So it doesn't matter where you see this lesion, as long as it follows those criteria, you're still going to call it dentigerous cyst, okay? And it has to be associated with an impacted tooth. Because there's different ways a dentigerous cyst can present. radiographically. There's one type called the central type. Okay, so the central type is basically what you're seeing here. So it looks like, you know, the radiolucency is surrounding the entire crown of the tooth, right? Then you have something that's called a lateral type. Okay, so you only see this radiolucency on the side of a tooth. Okay, and that's usually associated with impacted mesioangular impacted teeth. So do you guys know the difference between different kinds of impactions? Okay, so when you look at teeth, right? So if it's upright like this, then it's a vertical impaction, right? If it's tilting towards, you know, the mesial aspect of the other teeth, then it's a mesioangular impaction. If it's going the other way, what would it be? Distoangular impaction, right? And then if it's flat like this, horizontal impaction. Okay, so typically if you're seeing a radiolucency associated with a tooth that's impacted sideways mesially, then you get a radiolucency that's more on the lateral side of the tooth rather than seems like surrounding the entire crown of the tooth, but it's still a dentigerous cyst. And sometimes you can have a radiolucency where it goes beyond the CEJ and actually goes to the apex of the tooth. Okay, so it looks like the entire tooth is actually sitting inside the radiolucency, and that's called the circumferential type. Okay, you don't have to know the subtypes when you're writing the diagnosis, right? As long as you say that it's a dentigerous cyst, that's good enough. You don't have to tell it's a central, you know, lateral, circumferential, none of those. So the other name for dentigerous cyst, it's called a follicular cyst. That's basically because it looks like, you know, a follicle around, you know, a developing tooth, right? It's a very, very common type of cyst. So this is something you will encounter in your clinical practice. So a lot of patients, you know, if they have impacted teeth, they tend to have, you know, something that if it's a cystic process, it tends to be dentigerous cysts. So 20% of all the cysts that arise in the jaws that are true cysts are actually dentigerous cysts. Okay, we don't know exactly what the pathogenesis is, but then the reason why you would see a dentigerous cyst is because there's fluid that gets accumulated between the crown of the tooth and the epithelial lining. Okay, so that causes, you know, the separation of the follicle from the crown of the tooth, right? So, and as more and more fluid gets accumulated, you're going to have enlargement of this, you know, cystic lesion there. So if you aspirate it, you're going to get fluid from it, right? So this is common pretty much in younger patient group, right? So patients, you know, who have impacted teeth, you typically tend to see this. It tends to have a slight male predilection, okay, compared to women, and the more commonly it's associated with mandibular third molars. So that's the most common site presentation for dentigerous cysts. Yes.
Does this like stop eruption at all?
Yes.
It does.
Yeah. So anytime you have a cystic process around a tooth, and if the tooth is in the line of eruption, then that cyst process can, you know, prevent the eruption of the tooth. Okay, but any impacted tooth, you can see a dentigerous cyst, right? But more commonly, you see it in third molars. What's going on here in this example? So what are the features that you guys see there? It's radiolucent, unilocular, corrugated. It's pericoronal. But what else happened there? I'm sorry? Yeah, but what happened to the tooth? Is that the normal positioning of the tooth in the sinus? No, it actually displaced the tooth upwards, right? Towards the sinuses, right? So, and that's not, so sometimes dentigerous cysts, remember I said it's because you see fluid accumulation in the cystic, in the area between the tooth and the lining, the follicle, you get fluid gets accumulated, and that's how it leads to this, you know, enlargement here. So as more and more fluid gets accumulated, it can actually push or displace the adjacent teeth. Okay, so you can have teeth actually going down all the way to the inferior border of the mandible. You can have teeth being pushed into the sinuses. So it can do that, right? That's because of the large size that they acquire over a period of time if it's not treated. So again, that's the same thing that's going on here, right? So you have a tooth now displaced towards the inferior border of the mandible, and that's not its normal location, again, because it gets extremely large. So this is the entirety of the lesion, right there. Right? So they can get extremely large if they're left untreated, okay? And surgery becomes really difficult here. Okay, so how do we treat a cyst? So typically the best way to treat a dentature cyst is what's called enucleation. So you basically open a bony window and then scoop out the entire cyst lining. Okay, so that's what enucleation means. And then if there is a tooth that's associated with it that's impacted and it's not in the line of eruption, then you extract the tooth associated with it. Okay, but sometimes if it's a really large cyst, like the example that we have seen before, this would be surgically very difficult, to manage, right? Because we don't want to, go in because it thins out the bone significantly there. So there's a potential for pathological fracture in a patient like this. So what they'll try and do is a procedure called marsupialization. So this is what it is. So marsupialization, what happens is you're trying to decompress the cyst. You're trying to get rid of the fluid within the cyst. Okay. So what they'll do is they'll create a window, the surgeons, in the bony window, and then they'll put a drain in there. Okay, and the drain opens into the oral cavity, and then over a period of time it actually decompresses that lesion. Okay, so when you do that, now look at the difference between the lesion here, right, and then the size of the lesion here. So it's a significant reduction, right, because there it's actually extending into the ramus of the mandible. Anteriorly, it's going all the way to the first molar, and inferiorly, it's going towards the, near the mandibular canal. So, but if you see here, this lesion has significantly subsided now. It's pretty much right there, right? So that's the advantage of doing marsupialization. Now, surgically, it's a lot more easier for an oral surgeon to go in and then enucleate, or take out the cyst lining, right, and then extract the tooth. So this is one procedure that's done if it's a really large cyst. These have really good prognosis, but there are some complications that can arise from the lining of a dentigerous cyst. Okay, so there's typically 3 things that can arise from a dentigerous cyst, from the lining, cyst lining. It can be an ameloblastoma, which is actually a tumor. Even though it's a benign tumor, it's an extremely aggressive tumor, and the treatment for ameloblastoma is actually resection of the jaw. Okay, so this is something we'll talk about in Monday's class. Okay, so it's really important when you see someone and you're suspecting that the patient has a dentigerous cyst, you have to make sure that they see an oral surgeon to get appropriate treatment, because if you leave it alone, there is a slight possibility that it can turn into an ameloblastoma, or it can turn into a squamous cell carcinoma, right? So the lining that lines the cyst, right, can actually transform into a malignancy, or it can transform into a mucoepidermoid carcinoma. So there's different types of malignancies that it can transform into, or it can transform into this benign tumor, which is extremely aggressive, because the treatment for all of those is very aggressive, right? So you have to do resections. So imagine if someone comes in and if the treatment that you had to do for them was just, enucleating the cyst. Rather than that, if you let it go and not treat it, and then you have to resect their jaws, that's not going to be good, right? So that's a potential lawsuit waiting. Okay. So that's your dentigerous cyst. We'll move on to the next cyst. So I want you to pay attention to dentigerous cyst and odontogenic keratocysts, because these are extremely common. These are among cysts, that affect the jaws, and the likelihood of you seeing this in your clinical practice is more likely than not, right? So you should pay attention to how to recognize these things. Okay, so what do you guys see here?
I see distal impacted third molar.
Okay, so what looks like it almost looks like horizontal impaction. It's a third molar. Okay, what's going on here?
Big old radiolucency right there.
So you have a radiolucency. Okay, so this is the radiolucency right there. Okay, what else? And this is your impacted tooth. So it seems to be peripheral. So it seems to be going from one aspect of the crown of the tooth to the other aspect. Absorbed by the other tooth. Yeah, it's obscured right now, so it's hard to tell. But what else? So this has a corrugated border. I think I heard someone say that.
Yeah.
Okay. So what would you consider on the top of your differential here? Dentigerous cyst, right? But this is not a dentigerous cyst with biopsy. Okay. But what else are you seeing here? What the way it's growing? When you saw the examples for dentigerous cysts, how did they grow? This way, right? They went from here to here for the most part, and then they also went this way, but there was buccolingual expansion. Here, what is it doing? It's going anteroposteriorly, right? So it's going this way. It's almost like a cloud. It looks like a cloud, okay? So this is a feature that you tend to see with odontogenic keratocysts. So they tend to grow more anteroposteriorly. So even when they get to this size, clinically, you may not see a swelling in a patient. Okay, that's because they tend to grow top to bottom, not, actually it's front to back, right? So it goes this way. It doesn't go sideways. But if you look in a dentigerous cyst, it tends to go, basically buccolingually. So that's where you can have expansion when they get to this size, right? But in an OKC, you don't see that because of the growth pattern. Okay, so that's critical. They tend to grow in an anteroposterior direction. Okay, and they also are typically associated with an unerupted tooth. So up to 40% of the cases can actually be associated with an unerupted tooth, and that's why they can easily be mistaken for a dentigerous cyst. So when you see this, and if I ask you what is on the top of your differential diagnosis, you're still going to tell me it's a dentigerous cyst, but then if the radiographic appearance looks like this in the right context, you also have to consider odontogenic keratocyst in your differential, because dentigerous cyst, this is not the radiographic presentation typically, even though everything else matches. Does that make sense?
So
Yes.
if you have both of them on multiple choice, which one would you choose?
I want to ask you something like that, don't worry. No, the question is not to trick you. It's basically, do you understand the concept, right? So if you saw something like this, if I ask you what is on the top of your differential, because of the anteroposterior growth pattern, you have to consider OKC, or odontogenic keratocyst, on top of your differential. But if it's growing buccolingually, and if I told you clinically the patient had expansion, buccolingual expansion, what would you consider then? Dentigerous cyst in your differential, right? So, but then if I ask you give me two differentials for this, then you should consider both in your differential diagnosis. Okay, so this one is, comprises about 3 to 11% of all odontogenic cysts. So dentigerous cyst was the most common, right? It was 20% of all odontogenic cysts was dentigerous cyst, whereas OKC is only 3 to 11%. And please do not write the term OKC in your answers. I'm just using it because I don't want to say the whole thing out, but that's not your diagnosis. You have to spell it out, okay, in your quizzes and your exams. It's a developmental cyst, and this arises from dental lamina. You remember from the embryology picture that we looked at, we talked about dental lamina that comes from the oral cavity, like this thin strip of epithelium. So if that epithelial lining kind of persists during tooth development and it doesn't go away like it should, then it can give rise to an odontogenic keratocyst. Okay, and this is again seen from anywhere from 10 to 10 years of age to about 40 years of age. So it's a pretty wide age range. So typically when you see it in a younger patient, they're associated with a syndrome called Gorlin syndrome or nevoid basal cell carcinoma syndrome. Okay, so if you have someone with multiples of these OKCs, you have to basically get that patient worked up for that syndrome. Okay, so that's critical. We're not going to talk about the syndrome, but just remember, if you see a patient with multiple OKCs, you have to basically make sure that the patient doesn't have a syndrome that it's causing these lesions. Okay, this also has a predilection for mandible, just like dentigerous cyst. Okay, and it's also posterior mandible, like dentigerous cyst. But the difference is it grows in an anteroposterior direction, and that's how you kind of differentiate radiographically between a dentigerous cyst and an OKC. Again, same thing here. What kind of a pattern do you see here? This is not the greatest quality. There's some artifact here, but you can appreciate some changes here. What kind of changes do you see here? Is it radiolucent?
Yeah.
Yeah. Is it corrugated?
Yeah.
It has a very thin border on the top superiorly, right? What is the extent of the lesion here? Going all the way from here going into the ramus of the mandible, closer to the condyle and the coronoid process, right? So it's a pretty expansile lesion, but how is it growing again? The same anteroposterior direction. And imagine if you draw a cloud, it has the appearance of a cloud. Okay? So that's why that's that cloud-like appearance that you're seeing. But what else is happening here?
Resorption.
What's happening to the tooth? Root resorption. What kind of a resorption pattern is it showing? Is it straight or is it kind of spiky? It's actually a blunt resorption. Okay? That's called blunt resorption. When you see a blunt resorption, it's suggestive that it's a benign process. Okay? Let me see if I have a picture of that here. See this. And you guys can appreciate that. So you have the lesion, and what kind of a resorption pattern it is? It's straight, blunt, right? So if you see this kind of a resorption pattern next to a lesion, basically it's suggestive that it's a benign process. If it's a malignancy, then it's not going to have this kind of resorption. It's going to be spiking like this. So it's irregular resorption. Okay? It's not going to be a nice, smooth, straight line. Okay? So that's something you have to remember with benign lesions. So they can be aggressive, but they're still benign. Okay, so and those are signs of aggressiveness. When it displaces the tooth, when it resorbs the root of the tooth, those are signs of aggressiveness. Yes?
Can you repeat that? Can be aggressive and benign?
Yeah. So does every lesion that causes, tooth resorption or tooth displacement have to be malignant? No. No, right? So you can have benign lesions that can do that, and you can have malignant lesions that can do that. But how do we differentiate between something that's benign versus malignant? Benign lesions typically, when they cause resorption of the tooth root, they cause a blunt resorption. So that means you can draw pretty much like a straight line, where the area is resorbed, right? But if it's a malignant lesion that's causing tooth resorption, then it's going to be more uneven or irregular, the type of resorption pattern. And that helps to differentiate significantly between whether it's a benign aggressive lesion or a malignant aggressive lesion. So they can present like this. And this is a critical thing to look at because the next cyst that we talk about, and we'll take a break in a couple of minutes, the next cyst we talk about can mimic an OKC, just like this. It's usually between a canine and a premolar, the location of this, and the teeth associated with it are usually vital. Okay, so it's interradicular lesion. So an OKC can present as an interradicular lesion, it can present as a pericoronal lesion, and this one looks more multilocular, right? Yeah. It looks like there's some septae coming through. So OKC can also have a multilocular appearance. So it can have a unilocular appearance, it can have a multilocular appearance, but they're always radiolucent. OKCs are never radiopaque or mixed. Okay? So I want you to keep that in mind. And people get confused with septations and mixed radiopacities. When you see septae, that's not a radio-opacity, okay? So that's just bony trabeculae that's dividing this lesion into different locules, right? But if it's a true radio-opaque lesion, that material, the radio-opacity, is going to be an integral part of the lesion. It's going to be laid down by the cyst or the tumor. Okay, and you can see some examples as we go forward. So, again, same thing, you have that cloud-like radiolucency that's extending. And what is it doing? It's resolving the root of the tooth, and it's actually displacing the tooth here, but it's going anteroposterior direction. So it's following all of those features of an OKC, right? So it's associated with an impacted tooth, which can be seen in up to 40% of cases. It grows in an anteroposterior direction. It's an aggressive lesion, even though it's benign. So you can see tooth resorption or tooth displacement in these. It can sometimes look like this. In the area of a missing tooth, you can have the appearance of a radiolucency, and that can also be an OKC. So histologically, what's unique about this is the lining. Okay, and I want you to pay attention to the lining here in OKC. So if the surgeon goes in and then scoops out the cyst lining, this is what you will see. It's a really thin cyst lining, right? It's not very thick. So usually it's about 6 to 8 cells thick. But what you look at the bottom of it, what do the cells look like? Do they look like they're parallel to each other? They're kind of laid up right next to each other, right? So that's called row of tombstones. They look like, a row of tombstones, basically. So, and they're palisading. So they are all, kind of lining up right next to each other. And it's not very thick, it's a very thin layer. And this layer towards the lumen of the cyst, or the interior of the cyst, basically has keratin. Okay, so this is a parakeratin layer. And if you do aspirate this cyst, you get usually a yellow cheesy kind of material, and that's all keratin. So that's why it's a keratocyst, because the cyst makes keratin. Okay, and it's lined by that keratin wall, right? So this epithelial lining has the keratin in it, as well as the internal aspect of the cyst has this cheesy yellow keratin material, right? So whenever a surgeon goes in and aspirates the cyst, and then they see that if the lining is extremely thin, we pretty much know that this is an OKC. It's going to come back as an OKC. So you enucleate these cysts and you curettage them. But the problem with this cyst is if you don't take it out entirely, because the lining is so thin, a lot of times when the surgeon is trying to scoop out the lining from the bone, they may not be able to get all of it. Okay? So you may leave some elements of the cyst lining inside, the jawbone, or it has a lot of like satellite cysts that it forms, this lesion. So they can go get transported into different locations in the bone. So even if someone, scoops out everything, they still may be some residual lesion left in there. And then that can lead to a high recurrence rate, sometimes as high as 60%. So even if they treat it, there's a 60% chance it's going to come back. And then you may have to be a little bit more aggressive with your treatment, and you can't just do enucleation and curettage at that point. Okay, why don't you guys take a break until 10:05, and then we'll come back.
Or you're so quiet.
I have a problem.
Yep.
I didn't do last 2 quizzes. I did study. I think it's a problem that I don't read the question really well, and I have a lot of people like right in front of me who's taller. And I should
Try and sit in the front row.
I should do that. I couldn't see it, so I didn't read it. I thought I heard the smoking, so I was like, oh, it's a smoke, and I just changed it.
Yeah.
And I keep changing like something like that. I only that part on the bottom part that I didn't see it. Everything was there, the key points, and then I missed it all.
Yeah, I think it would be a good idea then to, have a seat at the front or even like on the side like this, because if that's something that you're recognized, that
And
is
then
the issue.
for
Then
okay, so like other first 2 lectures that we had to study for this one, except the cancer part, that was very like obvious to recognizable, like to see, like recognize, distinguish between difference. But for the like cancers, it's everything is parotid gland. Everything is in parotid gland. What's the best way to study that part?
So the critical thing you have to know is whenever you look at any kind of lesion, it's what is the likely occurrence of that lesion, right? And if you're looking at a site, what is more common in that site?
Is more important.
I wouldn't say site is more. It's in the whole context of things,
but
right? For
more
some,
like a
site may be more important. Like there's some lesions that occur only in some sites. You don't see them elsewhere. There's some lesions that occur only in some other sites, right? So site is an important thing.
And then
the clinical presentation, right? So you have to be able to know, is it a white lesion, a red lesion, a yellow lesion, is it a red-white lesion combination? Is it a mass? If it's a mass, then how is the mass presenting? Is it presenting as a well-defined mass, or is the mass look like it's, the skin is broken through, it's ulcerated? Is the lesion area around it, is it indurated? How long has the mass been there for? Is it slow growing? Is it fast growing? Because usually if it's a slow growing lesion, they tend to be more benign, right? If it's a fast growing lesion.
But even though it was a malignant, it was all slow growing from the
No,
most of
what malignancy? The picture that she showed in the parotid,
no,
the big one?
from the lecture. No, it was low growing though.
Which lecture are you talking about?
Okay, hold on. Wait a minute.
I'm just talking about general principles. If you have a specific question about a specific topic, then bring it to me and then we can talk about it. But you have to think more along the lines of general principles. You know, like how do you differentiate between something benign versus malignant? And we had that lecture in neoplasia about how do you differentiate between a benign tumor versus malignant tumor. What features do you need to look for, right? And you apply that to all of these entities and then say, does it look like it's well defined? Does it look like it's slow growing? Does it look like it's not invading any adjacent structures? You know, what are all the features that you're seeing that it's suggestive of that?
Is there any way that I can practice on instead of just studying by myself?
Yeah, I would recommend that you study in. Do you have group sessions? Like, do you study in a group or it would be a good idea to kind of, you know, especially if you study in a small group, you know, people that kind of are inclined the same way that you are, you know, with regards to student reading habits and stuff. It would be a good idea to do that because then you can kind of test each other about topics and then kind of go back and forth. Because if you are just memorizing stuff and not applying what you're learning, then it doesn't really help, you know. So if you guys can look at a few pictures, you know, a few cases and then say, okay, you know, based on this presentation, this is what it looks like, you know, this is how I'm going to approach it. It's always a good idea to talk it out rather than...
I did a good job. A general pad, I did okay. And then every single like oral pad starts, it's dropping all the way.
But if you've noticed that, you know, you need to, you know, you're not able to see, it's a good idea to remove
I'll do that next time.
because you have at least a couple more quizzes left and then you want to basically... Yeah, but I mean, you can use one of these chairs to sit, you know, on the side and it should be fine. Yeah. Okay.
I have a question. For the quiz, why was it mucoid reaction?
Mucus escape reaction?
Mucus escape reaction. I thought it was salivary duct cyst because it said trauma.
Which is more common, a salivary duct cyst or a mucus escape reaction?
Yeah, I guess a mucus
escape reaction. That's the most common site for a mucus escape reaction. It's actually on the lower lip, on the labial aspect. So that's because, you know, that's the area that people more commonly tends to traumatize. The mucus escape reaction is secondary to trauma, right? So basically, yeah, it's an irritation or trauma. What it does is it can, you know, injure the duct in that area and then you have backup fluids, you know, in that area. So, but mucus escape reaction is the most common lesion that you see in that site.
You know, in the description of salivary duct cyst, it said caused by trauma as well.
Yeah, but you have to always consider there's so many things that have trauma. Like linea alba can be, you know, because of someone sucking the cheek. Morsicacia is because of trauma, you know. But does that mean that we would include morsicacia in there? No, right? So it's in the context of what is the clinical presentation, what is the most likely entity that's, you know, arises in that area, and does it match everything else? You know, salivary duct cyst, that's not the most common lesion.
And for, so where would you see salivary duct cyst mostly?
Where do you see it? I'm not the one who's going to be answering that.
I know.
You should read up and then, yeah.
So, okay.
So you need to, so whenever you look at two things that can look very similar to each other, that can have a similar etiology, you need to be able to write down things that differentiate one from another, right? So I would do like a small table and say if salivary duct cyst and mucus escape reaction are two things that can get confused, you know, that may mimic each other, then how do I differentiate the site? Does that help me? Is the mechanism behind it? Does that help me? You know, is the history of, you know, that it actually gets bigger and smaller? Does that help me? Because that's what she said in the history is it gets bigger and smaller. Do you see that with the salivary duct cyst? No, right? So all of those things. So it's in the context of, you know, what's being presented to you, not just one single thing.
And for the one of the guy that had the big giant.
Let me start the lecture and then we'll talk about it after class.
Yeah, so I feel like it's usually mine. If I thought,
sounds good. We'll talk about it after class. Sure, because we're gonna get started. Okay. Sorry. Okay, guys. Please go ahead, take a seat. We're gonna go ahead and get started. Okay, we've got a few more entities to cover, so I just need you to focus. Okay, I'm going to go ahead and get started. Okay, so what do we see here in this radiograph?
Radicular cyst.
It's okay, what do you start off with?
Radiolucent.
It's radiolucent, okay? It's unilocular.
Oh, look
I don't know where
It's interradicular, that's right, okay? So you have unilocular radiolucency that's between the roots of two teeth. Is it corticated?
No.
No, it's not, right? So this is not corticated. So this is a big difference from the ones that we've seen before, but doesn't mean that all of these are not corticated, right? You can have some of these that can be corticated. But when you do a vitality testing of the teeth that are adjacent to it, they're going to test vital. Okay? So what two teeth is it between? It looks like it's between a lateral and a canine, right? So basically, that's the most common site for the cyst that you see here. It's called a lateral periodontal cyst. So lateral periodontal cyst, right? So the most common site is usually anterior mandible, either between a canine and a premolar or between a canine and an incisor. But it's usually more common in the anterior mandible, okay? And the teeth that are adjacent to this cystic process, they're usually vital, okay? So this is a lateral periodontal cyst, okay? The key features to remember is it's always interradicular, so that means it's between the roots of the teeth, okay? And the teeth adjacent to this lesion are usually vital. This usually presents as a unilocular radiolucency. Okay, so that's your features with lateral periodontal cyst. So what would this commonly get confused with? So if the teeth were non-vital, right, what would you confuse? Does that look like a malignancy?
Periapical.
How? Why?
not corticated out.
Does that mean it's malignant if it's not corticated? It's just that body didn't have enough time to form a bony barrier, but that doesn't mean it's a malignant process, right? It still looks really well defined. What is it?
Periapical cyst.
Yes, so it can be actually confused with a radicular cyst or a periapical cyst if the tooth has an accessory canal. Because typically you're supposed to see a radicular cyst or a periapical cyst. Where would you see it? As the name suggests, where would you see it?
Periapical.
At the apex of the tooth, right? But if you see it, on the side of the tooth, sometimes you can see a radicular cyst on the side of the tooth, because some teeth, they don't have one canal, right? They'll have accessory canals. So if that accessory canal got infected, it can present as a radiolucency on the side of a tooth. But it's still a periapical cyst or a radicular cyst, but you call them lateral periapical cyst or lateral radicular cyst, because the lesion is on the lateral aspect of the tooth, right? But the teeth here are going to be either have pulpitis or pulpal necrosis in them, right? But in a lateral periodontal cyst, would the teeth have any of those features? Inflammatory source? No, right? Because it's a developmental cyst. So that's how you differentiate. So if you see a lateral periodontal cyst, and if it's lateral periodontal cysts are typically in the bone, right? But if you see something that's similar to a lateral periodontal cyst histologically, right? So under the microscope, it looks exactly the same. But if it's seen on the gingiva only, and there's no bony involvement, then you call it gingival cyst of the adult. So gingival cyst of the adult and lateral periodontal cyst look exactly the same under the microscope. Okay? The difference is lateral periodontal cyst arises in the bone, and gingival cyst of the adult is only in the soft tissue on the gingiva. Okay? This is not very common, as I said again earlier, that this is not something you'll likely see in your clinical practice, because it's only less than 2% of all the cysts that can arise in the jawbones comprise of lateral periodontal cyst. But you should know about it, because why it gets confused with the lateral radicular cyst, right? It can also arise from the dental lamina, and you should know the site for this lesion. Okay? And remember, in a previous example, I showed you an OKC, an odontogenic keratocyst, that mimicked this one, right? So we looked at this example, and I said, pay attention, because it mimics the lateral periodontal cyst. So if you just saw this one, it's hard to tell, right? And if the teeth were vital, what would you include on the top of your differential? A lateral periodontal cyst, right? So if this was your radiographic presentation, this is what you got in your exam or quiz or in your patient, and you know that these two teeth are vital, and you're seeing a unilocular radiolucency between the roots of two teeth, and the teeth adjacent are vital, you are going to consider a lateral periodontal cyst on the top of your differential. But if I ask you to give me two differential diagnoses, then you include OKC in your differential. Okay, because OKC can mimic anything in the jawbone, unfortunately. And that's why it's a much harder diagnosis. Again, common theme here is its location, right? And its presentation. In all these examples that you have seen, it's presenting as a unilocular radiolucency between the roots of two teeth, and the teeth either tend to be between premolar canine or between a lateral incisor and a canine, or between a canine and between two premolars, but it's all typically in the anterior mandible, some maybe a little bit posterior when it comes to premolars. Very rarely you'll see a lateral periodontal cyst present as a multilocular radiolucency. It's not very common. That variation is extremely rare. Okay, and we use a term that's called botryoid odontogenic cyst to describe that. And the reason why you use that term, because it looks like a cluster of grapes. Okay, so that's why you use the term botryoid to describe it. But it's not common, so don't worry about learning about it. Okay, I just want you to know about it. Same thing here. These are from your textbook. And what is the problem here in this radiograph? Apart from the radiolucency, do you see anything else?
The pulp chambers are huge.
Exactly. And what did they do there?
They're pushing into the pulp. The cyst
So
is
he
growing
said
up.
the pulp chambers look larger, right? Why?
Because the cyst is growing up into the teeth.
No. Does that look like it's growing up into the teeth?
That's the source of inflammation.
No. It's a lateral periodontal cyst, so it's a developmental cyst, right? So you're not going to have any source of inflammation. The teeth are vital. But what did the dentist do? Decide that they wanted to do root canal therapy, right? On vital teeth without actually establishing a diagnosis. And this is wrong, right? You have to make sure when you see this, something like this, that you encourage your dentist to do a vitality test before they start doing endodontic therapy. That's a very common mistake that happens. Yes?
So this is gingival cyst of...
No, gingival cyst of the adult, only in the soft tissue, never in the bone.
Okay.
Okay, so let's get this clear, right? So far we talked about three cysts: dentigerous cyst, odontogenic keratocyst, and lateral periodontal cyst. Okay? What is the most common site for a dentigerous cyst?
Young adult.
Common site.
Oh.
Posterior mandible, third molar, right? What is the most common site for odontogenic keratocyst?
Posterior.
Posterior mandible again. What is the most common site for lateral periodontal cyst?
Lateral.
Around the canine.
It's usually between canine and premolar or canine and incisor, right? So it's usually more anterior, not posterior mandible. Okay. So are teeth vital in all of these?
Yes.
Yes, it's hard to test vitality in a dentigerous cyst because it's associated with an impacted tooth, right? So don't worry about vitality there, right? But the other two, the teeth tend to be vital, okay? Which two of these, of the three things that we talked about, can present as interradicular radiolucency? So that means between the roots of the teeth. Lateral periodontal cyst and OKC. So LPC and OKC both present as unilocular radiolucencies between the roots of the teeth. Which two of them can present as pericoronal radiolucencies? That means around the crown of an impacted tooth. Dentigerous cyst and OKC. So when you guys are studying, that's how I would make lists, right? So it's not about just memorizing clinical pictures, because they can all look exactly the same, right? So please make short lists of things that can have similar radiographic presentation. And then you look at it and then say, how do I differentiate between these two entities now, or these three entities? What are the features that help me differentiate? Okay, so that's critical. So again, this is not the most common pattern. I'll skip that. It'll confuse. So the way you treat lateral periodontal cyst is basically by enucleation, right? It's a cyst, so you're trying to enucleate the cyst lining, so take it out completely. And as long as you take the entire lining out, they usually don't come back. You know, they have pretty good prognosis. So this is your gingival cyst of the adult. Okay, so if I took a biopsy of a lateral periodontal cyst, and if I took a biopsy of the gingival cyst of the adult, they both are going to look very similar under the microscope. But what is the difference? So if I didn't tell you where the biopsy came from, will you be able to tell the difference? What diagnosis it is? No, right? But if I told you this came from just gingiva, from the soft tissue, and there was no bony involvement, then you're going to call it gingival cyst of the adult. But if I told you this basically came from the bone between the roots of two teeth, then what were you going to call it? Lateral periodontal cyst, because histologically they look very similar to each other. So two things that can look histologically similar to each other are lateral periodontal cyst and gingival cyst of the adult, right? And how do we differentiate between them? Is basically one is in the bone, which is your lateral periodontal cyst. The other one is just in the soft tissue on the gingiva. So if you see this is something you might be the first person, diagnosing a patient, right, with this disease, because it's a soft tissue lesion. So you need to make sure that the patient gets a biopsy done, get this removed, and then have a diagnosis established. Ideally, if you see something like this, I would also get an X-ray of that area, right, to make sure that there's no bony involvement, because sometimes you can have bony lesions that can break through the bone and then present as a mass, on the soft tissue. So you want to make sure that this is not arising from the bone and it's all in the soft tissue. But if you look at this lesion, how do you describe it? Okay, is it an exophytic lesion? Is it like a something that's growing outwards or growing inwards? Is it inwards? Okay, if this is a flat surface, right? Is it a bump that's projecting out?
Yes.
Or is it an ulcer going inwards? It's a bump, right? So this would be exophytic, right? So this is not an ulcer, it's not endophytic. Okay, so if this is a bump, is it well defined?
Yes.
Yeah. What is the color? It has a bluish hue to it, right? And it looks like it's actually filled with fluid, right? So if you touch it, it should feel fluctuant, right? So it almost looks like a mucus escape reaction, but it's actually on the gingiva. So it looks like it's filled up with fluid, but the location is basically on the gingiva, right? So that's why you have to consider something more cystic in your differential diagnosis. If this was a firm lump, then you're not going to consider gingival cyst of the adult on the top of your differential. But if it's a fluctuant mass that looks like it's filled with fluid, then you're going to consider gingival cyst of the adult. Okay? Okay, so again, the site is the same as lateral periodontal cyst, right? Predilection. So it's usually between mandibular canines and premolars, or canine and incisor. Okay, it again tends to be more common in adults, just like the name says, right? It's gingival cyst of the adult, so it's seen in adults, right? And like lateral periodontal cyst, and the color can be bluish, purple, kind of like this, or it can be a lighter color like the example on the top. But more commonly than not, they tend to have a bluish hue to them. Okay, it's not a very common lesion, but as I said, you could be the first person diagnosing this patient with this condition. So you need to be aware of that. When you're doing your cleaning, you have to make sure you look out for any of the changes on the gingiva. Okay, and the way you treat it, it's basically just simply excising it, and it has really good prognosis. Okay. So far, what were the two entities that I said that look histologically similar to each other? Gingival cyst of the adult? Lateral periodontal cyst, right? Is the site preference the same for both of them?
Yes.
Yes. And what is the site that they most commonly occur in?
Lateral to the canine.
So it's between canine and premolar, or between canine and incisor, right? Is it maxilla or mandible? Mandible. Okay. So how about if I saw a unilocular radiolucency at around the crown of an impacted tooth, and it's a pretty well-defined radiolucency, and it has a corrugated border. What am I going to consider on the top of my differential? Dentigerous cyst, right? We don't use the term follicular cyst as much, even though that's the term that's in literature. I would prefer dentigerous cyst. Okay. What else would you consider in your differential diagnosis apart from dentigerous cyst? Odontogenic keratocyst, OKC, right? So OKCs and dentigerous cysts, what is the age predilection for those? Is it more younger patient, younger adults, or like middle age? Young. Both OKCs and dentigerous cysts tend to be more common in younger adults, right? So less than 40 years of age, both of them. Okay. How about lateral periodontal cyst and gingival cyst of the adult? They tend to be more common in middle-aged adults, right? And then older adults. So which one of them presents as a radiolucency between the roots of two vital teeth? Lateral periodontal cyst. What else can mimic a lateral periodontal cyst in that location? A lateral radicular cyst if the teeth are non-vital. And OKC, right? I said bone. You cannot use the term gingival cyst of the adult in your differential diagnosis if it's a bony lesion. Okay? Okay, what do you guys see here?
Oh man, mixed, yeah, mixed.
Okay, so this is a mixed lesion, and that's critical, right? Recognizing that it's a mixed lesion. Why did you guys think this is a mixed lesion? Because there's radiopacities. So you have what looks like a radiolucency, and then this area right here in the center is a radiopacity, right? So you have multiple radiopacities kind of clustered in this radiolucency. So this is considered a mixed lesion. The reason why you call it a mixed lesion and not a multilocular lesion, please know the difference, right? Multilocular lesion will basically have like septate, like little lines that are going to, convert this radiolucency into multiple locules. So whereas in a mixed lesion like this, where you actually see the radiopacity mixed with the radiolucency, the cyst or the tumor is actually laying down this product. Okay, so it's an integral part of the lesion. Okay, it's not bony septae that are giving this appearance. So that's why this is considered a mixed lesion. And I see this very commonly, the confusion between multilocular radiolucency and mixed lesions. So whenever you look at a radiograph, you guys have to pay attention to what kind of lesion you're looking at, because that changes your differential diagnosis significantly. Okay, so if you're looking at this, this is a mixed lesion. Okay, so this is an entity that's called calcifying odontogenic cyst. Okay, so as the name suggests, it's a cyst. It's odontogenic in origin, so it's basically associated with during tooth development, right? And then it's calcifying, so that means it's going to have products in there that make it look radiopaque. So there's calcifications in there, right? So sometimes before you actually start seeing these calcifications, it can actually just look radiolucent. So depending on what stage you're looking at this cyst, it can vary from either a purely radiolucent lesion or a mixed lesion like this. Because as they calcify more, it's going to look more mixed. But if it's in the initial stages, it's going to look more radiolucent. Does that make sense? So this one tends to be more common in the anterior portion of the jaws, even though this example is posterior. There's always exceptions, right? You don't need to know this classification. I'll skip this. But this tends to be, there's no kind of, predilection by the maxilla or mandible. You can see it in both. But if you do see it, whether in maxilla or mandible, it tends to be more common in the anterior portion of the jaw, okay, rather than posteriorly. There's no kind of gender predilection here. Age, it tends to be more common in younger patients, okay, usually around 30 years of age or lesser. And then you tend to see them as either radiolucent lesions or mixed lesions. Okay, so the way you treat a calcifying odontogenic cyst is by enucleation. It's a cyst, so you remove everything, the lining, and it has really good prognosis. So this is one of the few cysts that actually calcifies. that can present as a mixed lesion. Okay, so there's not many cysts out there that can actually present as a mixed lesion. They all tend to be radiolucent, right? They can be unilocular, multilocular, but there's, calcifying odontogenic cyst is pretty much the only one that can have these calcifications in them. They can have other tumors that can have calcifications in them, but this is pretty much one that has a mixed appearance to it. Okay, so what do you guys see here? What kind of a radiograph is this first? It's an occlusal, right? So where is the problem here? On the molar. Okay, so you guys recognize it correctly. There's something going on here. Where is the problem? Is it on the buccal aspect or lingual aspect? Buccal, right? The tooth seems to be lingually positioned, right? But it's actually on the buccal aspect. So if you look on the buccal cortex right there, does it look like it's radiolucent there? Right here? Is that normal? Because that's where your cortex is, right? But look at here. You start seeing that it's ballooning out. So it's kind of expanding there, and then it looks radiolucent. And this molar right here is actually tilted a little bit more lingually, right? If you look at the occlusal plane, the rest of the teeth are all aligned in one plane, So you can kind of draw a line along the cusp tip, along the incisal edges, and then go to the center. And then this one is more lingual. You can actually see the lingual roots right there, right? So this is a type of cyst that's called a buccal bifurcation cyst. Okay? So this is a type of inflammatory collateral cyst. Remember when we looked at the classification earlier? We said we have developmental cyst and you have inflammatory cyst, right? So far everything that we have studied, that is the dentigerous cyst, OKC, lateral periodontal cyst, gingival cyst of the adult, they're all developmental cysts. Whereas this one, buccal bifurcation cyst, is actually an inflammatory cyst. So that means you need a source of inflammation for this lesion to arise, right? So typically it affects the mandibular first molar. Okay, this buccal bifurcation cyst. So the main classification is inflammatory collateral cyst. There are two different subtypes, buccal bifurcation cyst and paradental cyst. Okay, am I confusing everyone, or is that clear so far? Okay, so you have there's a main category that's called odontogenic cysts, right? Now odontogenic cysts can be developmental cysts or inflammatory cysts. So you have developmental cysts, examples so far are dentigerous cyst, OKC, lateral periodontal cyst, and gingival cyst of the adult. Okay. Under your inflammatory cyst, it can be either a radicular cyst, which Dr. Richards covered in Wednesday, and then, or you can have inflammatory collateral cyst. Okay. So in inflammatory collateral cyst are two subtypes. You have a buccal bifurcation cyst and a paradental cyst. Okay. So a buccal bifurcation cyst typically is seen in association with a mandibular first molar. Okay, maybe with second molar, but it's usually first molar. Okay, whereas a paradental cyst is typically associated with the third molar. Okay, so that's the one that can mimic a dentigerous cyst, a paradental cyst, but it's associated with the third molar. So typically when you see a buccal bifurcation cyst, it's common in children. Okay. And they're about 30% of the times it's actually bilateral, so that means you see it on both sides. Okay, and then you see that there's buccal expansion, and then sometimes it can actually cause bone to form on the outside because it's inflammatory, so body is reacting to it. So it can cause layers of bone, almost like an onion skin layer. Okay. So this is an example of a paradental cyst. So you have what looks like an impacted, third molar, right? And then you see a radiolucency on the lateral aspect of it. If you didn't know any history or any information, what would you call that? A dentigerous cyst, right? Because it's associated with an impacted tooth, a molar. But again, if we tell you that there's inflammation associated with this tooth, and this is the reason for it, then, or sometimes what happens is you can have an enamel extension. So on the tooth itself, you can have like a little bulge of enamel kind of protruding on the buccal aspect of the tooth, and then that can be a source of inflammation. Or it can be a deep pocket in that area that can be a source of inflammation with buccal bifurcation cysts or periodontal cysts, right? And then that's what leads to these cysts to come about. Does that make sense?
Can this happen on the lingual as well, or is it only?
It's usually on the buccal, right? So buccal bifurcation cyst and periodontal cyst is usually on the buccal. So you need to have a source of inflammation for these lesions to come about, and the source of inflammation is usually either the patient has some kind of enamel defect in that area that can lead to this inflammation to come about, or the patient has a deep pocket on that tooth on the buccal side that can cause this a cyst to come about, or if they have pericoronitis, right? If it's an impacted third molar, that can cause a lesion to come on. Okay. Bless you. The way you treat it, it's enucleation, and you don't have to extract the tooth if it's properly erupted and if there's no problem with it other than the cystic lesion. You just have to, if there is an enamel projection, you just smoothen it out till you take the source of inflammation. If there's a periodontal pocket, you have to make sure that that gets addressed, right? But you have to take the source of inflammation, and typically it heals within 1 year after surgery. Okay, so what do you guys see here? What part of the mouth are we looking at? Hard palate. What's the normal structure behind the two anteriors on the palate?
It's the
That bump. We'll talk about what that bump is. But what is the normal structure that you see between two central incisors on a hard palate? What is it? Incisor foramen is in the bone, but what is the normal structure in the soft tissue? The papilla, right? So this is your incisor papilla area, and internally in the bone, it will basically correspond to where the foramen is, or the nasopalatine foramen, or the incisor foramen. But is this normal? No. To see this bump? No, right? So basically, there is a cyst that's called nasopalatine duct cyst that arises in the area of nasopalatine foramen or incisor foramen. Okay? So this cyst specifically occurs in this area. You cannot miss this diagnosis because you do not see it anywhere else in the mouth. Okay? The only location that you see it is where there's incisor foramen or the nasopalatine foramen, right? So what do you see it as? It's seen as a swelling in the palate when it becomes the cystic process, right? So, and then sometimes when it's too big, it can push out facially on the buccal aspect, but most of the times the swelling is on the palatal aspect, right behind the two central incisors. Again, it may feel fluctuant because it's a cystic process, so when you palpate it, it may feel like there's some fluid in that area. Okay, it's a developmental cyst. It's a bony cyst, okay, and this is more common in adults. And so this is the example of sometimes how it can actually cause a buccal expansion. The majority of it is on the palate, but sometimes it can push through, through and through expansion, and then it can cause a swelling. And then see what is it doing to the face in that area? It appears that it's swollen, right? So if you feel it, it's pushed out. That part of the face, okay, where the cystic lesion is. Okay. So it's a very common cyst. So this is something you will encounter in your clinical practice. About 1% of the population actually has this lesion. Okay, so this is something that's pretty easy to diagnose. Okay, but the one thing you have to remember is how do you differentiate it from a normal incisor foramen, right? Because histologically, if you have this, how do you differentiate this between a normal incisor foramen? So clinically is one good point, because if it's a normal incisor foramen, you're not going to have any swelling in that area, right? It should look normal. Okay, so clinically is a good point, but radiographically, how will we differentiate? Is the size of the lesion. Okay, so if the radiolucency that you're seeing between two central incisors is larger than 6 millimeters, you have to consider nasopalatine duct cyst, okay, in your differential. If it's smaller than 6 millimeters, it's most likely anatomic, right? So that's incisive foramen. So it's the size of the radiolucency is what matters. Okay? So it's always between two central incisors. You know, sometimes it may have a little bit of a tilt towards the lateral incisor, but the meat of the lesion is always in the center. Okay? And there's actually three different ways that it can present. One presentation radiographically, it's called a heart-shaped radiolucency. So it looks like a heart. Okay? So why? Because you'll have a unilocular radiolucency. And what is the normal structure that kind of goes between the two central incisors superiorly? Your nasal septum, right? So the anterior nasal spine. So that's what divides this radiolucency, make it look like a heart. Okay? So it's actually a unilocular radiolucency, but because of the way the anterior nasal spine cuts through, it gives the appearance of a heart-shaped radiolucency. Or it can look like a pear shape. Okay? Like the example right there, like an inverted pear. Okay? So it looks like the fruit where you have the big bulk of it is at the top, and then as you go towards the teeth, it just gets a little bit narrower. Okay? Or it can be just an oval radiolucency like this. So there's different radiographic presentation, but the most common is the heart shape and then the inverted pear shape. Okay? And they usually very well circumscribed, and they typically tend to have a corrugated border around them. So this is another example. Okay, so again, this would be a little bit confusing, right? To differentiate between a normal incisive foramen versus a nasopalatine duct cyst. So you have to look for any clinical manifestations. You have to measure it. Make sure that your x-rays are calibrated when you're measuring these things, right? So as long as it's under 6 millimeters, then it's normal anatomy. Okay, or it can look like this, like a large radiolucency, and this is an edentulous patient, and that becomes really difficult to diagnose, right, in that area. But you see a large radiolucency with a corrugated border, and this has the shape of a heart, right? And so it's a broader base, and then as you come to the apex, it's a little bit narrower. Yep.
Would just be able to see that clinically because it's big?
Yes. Yeah. So those lesions, it's pretty easy to diagnose because clinically they have expansion in that area. Okay, and how do we treat it? It's basically by enucleation, and they rarely come back once you treat them. Okay, so far, all the cysts that we have talked about are true cysts. Okay, because the next two entities that we're going to talk about are pseudocysts. So please make a list of things that are true cysts and that are pseudocysts. Okay, and the reason why you call them pseudocysts is because they do not have an epithelial lining. Okay, but they mimic a cyst, but they don't have an epithelial lining. Okay, so true cysts, what were all the cysts that we talked about so far? Which one is the most common one? Dentigerous cyst, right? What is the next common one? Next most common? OKC or odontogenic keratocyst, right? And what are the two cysts that we said look histologically similar that are interradicular usually? Lateral periodontal cyst and gingival cyst of the adult, right? And then what was the other cyst that we talked about that is more commonly seen between the two central incisors, where you would typically see your incisive foramen? Nasopalatine duct cyst, right? And when you're writing down the answer, please write down nasopalatine duct cyst. It's not a nasopalatine foramen cyst. It's not a nasopalatine duct something. It's a nasopalatine duct cyst. Okay, that's a diagnosis. I mean, if you don't have all of those words in there, you're not going to get full credit for it. And then we also talked about calcifying odontogenic cyst, and that's not the most common cyst that you will encounter in your clinical practice. That's pretty much the only cyst that we've talked about so far that presents as a mixed radiolucent radiopaque lesion. Everything else was radiolucent, right? Out of the ones that we've talked about, which one presents as a multilocular radiolucency?
The OKC.
OKC. Okay. Odontogenic keratocyst is the one entity that commonly presents as a multilocular radiolucency. The rest of them, they usually present as unilocular radiolucencies. Okay? So far, so good? Okay. I'm sorry?
Have you seen that one?
I actually had, it was really interesting. Last year, I had 2 cases back to back, pretty much in the same week, of nasopalatine duct cysts. And one of them was a beautiful heart-shaped radiolucency. So that was a very easy diagnosis. But yes, you do see them quite a bit. So what do you guys see here? Okay, let's start with, is it radiolucent?
It's radiolucent.
Okay. Is it unilocular?
Yes.
Okay. Where is the radiolucency? Periapical. Is it spanning one tooth or multiple teeth? Multiple teeth. Okay. And what is the feature that you're seeing on the top right here? How is it going between the roots of the teeth? It's actually following the outline of the roots of the teeth, right? So it's scalloping between the roots of the teeth. So that's a feature that I want you to remember, okay, to make when you make this diagnosis. This is called simple bone cyst or a traumatic bone cyst. Is you have a radiolucency, which is unilocular. It spans multiple teeth, but it usually, when you look at the superior border of it, it scallops between the roots of the teeth. That scalloped border superiorly is a feature that's pretty much a giveaway for simple bone cysts. Yes?
What about on that side? It doesn't look like it has a border.
This one? You can still draw an outline, right? You know where it ends. So it's a well-delineated lesion. So ill-defined lesions is where you cannot tell where it begins. Lesion, ends, and then the normal tissue begins. But here you can actually draw a line all along the border. So even if it's not corrugated, we can still define the borders. So this is still a well-defined lesion. Okay, so this tends to be more common in younger patients, usually in like their second decade of life. Okay, so when you see a simple bone cyst. So this is not a true cyst. It mimics a cyst radiographically and histologically. So if I took a biopsy, it has the appearance of a cyst, but it won't have any lining in it. Okay, so you cannot call this a true cyst. So this is an example of a pseudocyst, a simple bone cyst. Okay, and the critical thing is that outline that you're seeing there, right? The pathogenesis, we're not sure exactly what is it that brings it on. There's different theories that have been put forward, but the one that's most popular is actually trauma hemorrhage theory. Okay, so basically what happens is when you have trauma to a jawbone, right? The trauma is not enough to actually cause a fracture in the bone, but then what it does is it can cause a hematoma to form in there. Okay, so that hematoma, if it doesn't organize itself over a period of time, it doesn't repair itself, then that can eventually become liquid, right? And then form like a pseudocyst in that area. So if you took a biopsy of a simple bone cyst, it's actually an empty cavity, or you're just going to have a lot of this bloody fluid in it, and that's it. There's not going to be any lining. So typically when the surgeon tells you that when they went to do the biopsy, they couldn't get any tissue from there, and all they had was just this bloody liquid, or it was empty, there was no liquid in it, we know for sure it's a simple bone cyst because we won't get any sampling from the surgeon. Does that make sense? The reason why is because patients usually report a history of trauma there, and when they have trauma, that trauma did not cause a fracture, but it caused a hematoma to form in that area. But that hematoma did not organize itself, it did not turn into bone in that area eventually, and then bone was not laid down, and then that hematoma basically became more like a fluid, right? It liquefied and then caused this. Okay, so this is not the, let's not do that, that's not the most classic example, so I don't want you guys to get confused. So simple bone cyst, the way you treat it is by basically going surgically, and you scoop out whatever you can find, or if there's nothing there, then you just aspirate the liquid from that area, and then just, curettage that bony socket that's being opened up, right? So you eliminate anything that's in there. Basically, once you do that, it'll usually take few months to at least a couple of years sometimes. So sometimes it could take almost like a year and a half or 2 years before that area completely has bone formation in it. Okay, so it could be anywhere from 1 to 2 years is the time period that you want to follow up these patients. Okay, so that was one example of a pseudocyst, right? Simple bone cyst, also called as traumatic bone cyst. And whenever you see a simple bone cyst or a traumatic bone cyst, the things to remember is if a surgeon goes in does the biopsy, they're not going to find anything there because it's just an empty cavity, or even if there is something, it'll more likely be a bloody fluid in there, okay? And then they'll just aspirate it, and then they'll curettage the socket, and then that's about it, right? So what is the reason why you see a simple bone cyst? What is the most common theory that's proposed? Trauma hemorrhage, right? So when there's trauma, there's submucosal hemorrhage, so you get hematoma formed, and then that liquefies when it doesn't organize itself. Okay, and what is the characteristic radiographic appearance of a simple bone cyst? It's a scalloped border superiorly between the roots of the teeth, right? And it spans usually multiple teeth. Okay, what do you guys see here? This is the last topic. It's radiolucent, okay? It's unilocular, corrugated border.
Within the bone of the mandible.
Yeah. What is how else would you describe the location? So this is unilocular radiolucency with a corrugated border.
At the angle of the mandible.
So it's near the angle of the mandible. That's critical. What else? Is it above the mandibular canal or is it below the mandibular canal? Below, right? So typically, if it's a tooth related, so if it's an odontogenic cyst or tumor, the center of the lesion usually tends to be above the mandibular canal. If it's something that's unrelated to odontogenesis or tooth development, then they tend to be below the mandibular canal. So this one has got nothing to do with tooth development. This is a defect that's called Staphny bone defect. Okay, but the critical things, as you guys said, is the angle of the mandible location. Because if you palpate near the angle of the mandible for these patients, you'll basically feel like a little notch or a depression. Because this radiolucency, kind of creates a depression in the bone in that area. And that radiolucency is basically comprised of submandibular gland tissue. Okay, so that's why it looks radiolucent. It's soft tissue. So this area here, sometimes you can have some submandibular gland ectopically present on the lingual aspect of the mandible. Okay, and if you palpate it, it's going to feel like a notch right near the angle of the mandible. Okay, so and then these lesions, when you see it, they typically don't change in appearance. So all you have to do for these patients is periodically follow them with radiographs. So once every 6 months or whenever you do the radiographs, you make sure that once you establish a diagnosis, this is a Staphny bone defect, you take those radiographs, and if it doesn't alter, you just repeat the radiographs every couple of years or few years. There's no treatment. You don't need to do a biopsy. You don't need to do anything else for these patients. It tends to be more common in males, and the site is very important. Angle of the mandible below the mandibular canal. Unilocular radiolucency, usually with a corrugated border. Okay? And you'll see a notch clinically. Yes?
Did you say it could be bilateral?
It may be bilateral, but it typically tends to be unilateral. Sometimes you can see it below the mandibular canal, but look at the inferior border. It kind of merges with the inferior border of the mandible. Okay? So, and in patients like that, the notching is going to be much more evident because now you can feel a clear depression right in next to the angle of the mandible. Okay? Occasionally, you can have a similar lesion, a Staphny defect, actually affecting the anterior mandible. This is an extremely difficult diagnosis. I don't expect you guys to know that because when you see this, even I cannot make a diagnosis just by looking at it, right? And I see this all the time. Okay? The reason why is it mimics other odontogenic cysts and tumors, right? So that's not the first thing you're going to consider. So you would recommend that the patient get a biopsy done if you see it anteriorly, if it's not in the angle of the mandible. And once the diagnosis comes back as just a salivary gland tissue, then you know that it's a Staphny defect. Then you don't need to do anything about it. But if it comes back as something else, we have to address it. Okay? So just remember that there could be a variation. Okay? And you can see these anteriorly, but that's about it. I don't expect you to make a diagnosis for that. But if you see this picture, you should be able to make a diagnosis that's a Staphny defect. And this is a straightforward diagnosis. This does not require a differential. right? So it's a final diagnosis when you see this. There's no treatment, and they have really good prognosis. I want you to remember one acronym, if you just want to write it down. Whenever you see a multilocular radiolucency, think of the acronym MACHO. M-A-C-H-O. Okay? M stands for myxoma, also known as odontogenic myxoma. I want you to write down the whole thing, odontogenic myxoma. We'll talk about it on Monday when we do tumors, and it'll make more sense. A stands for ameloblastoma. C for central giant cell granuloma or cherubism. C-H-E-R-U-B-I-S-M, cherubism. Okay?
That's also for C.
Yes. So M for odontogenic myxoma, M-Y-X-O-M-A. Okay? A for ameloblastoma, A-M-E-L-O-B-L-A-S-T-O-M-A. Okay? C for central giant cell granuloma or cherubism. H for hemangioma, and O for odontogenic keratocyst. Do you want me to repeat it again? And I'll repeat it on Monday too when we do the tumors. OKC or odontogenic keratocyst.
So these are multilocular.
Yeah. So whenever you see a multilocular radiolucency in a patient's jawbone, these are the 5 things I want you to consider in your differential diagnosis, because these are 5 most common things, actually 1 more, 6, that can present as multilocular radiolucencies in a patient's jawbone. So that's just a quick acronym to remember, the common things that can present. Okay? So I think you guys are going to get a break until 11:15, and then we're meeting in room, is it 1101? 2? Okay, for your exam discussion.
If we signed up for
Yes, if you did sign up, yeah.
Oh. I was like, what?
So I think Dr. Richards opened up the so whoever signed up for the 11:15 slot, please go to 1101 or 1102, whatever that room is.
Or was that always open?
I'm sorry?
She opened it. Wasn't that slot full?
I'm not sure.
Okay. Are you in the 11:15? Was it full?
I don't know. I signed up.
There's like multiple times that it should be open.
I signed up for the 12, but I just wasn't sure if 12 got into 11:15.
No, she had.
Okay, great.
Yes.
I was wondering, I signed up for the 12, but my carpool's going in at 11:15. Can I come in at 11:15?
You have to check with Dr. Richards.
I just
because
emailed
she
her.
prints your schools
And
and
I know she probably
everything, and then she has
organizes
us.
it.
Yeah, so I don't know if she has all of them, but if she's okay.